So good afternoon, everyone. I'm Janice Whitaker. I'm the CGNE Administrator and Community Liaison, and it's my pleasure to serve as the CGNE Seminar Series host. Today's seminar will be on elder abuse in Pennsylvania, what nurses and other healthcare professionals need to know. It'll be co-presented by two special guests that have been visiting our college this week. Stephanie Cole, Special Assistant Secretary Torres, and Denise Getgen, Director of Protective Services. Before this important and informative seminar begins, there are some announcements and disclosures. So first of all, this seminar is being recorded. You will be on Zoom. If you choose to have a question or a comment, please enter it into the chat or the Q&A feature at the bottom of your screen. We will be posting the post-event evaluation link into the chat at the end of the seminar, and it will also be emailed to those of you that registered for the seminar within 24 hours. The evaluation must be completed within 1 week. While this is required for RNs seeking contact hours, we do ask that all participants complete the evaluation, as this will assist with data collection, not only for our center, but for the Age-Friendly Care PA initiative. Contact hour certificates will be emailed to registered nurses meeting all the requirements within 1 month following the seminar. The Penn State Ross and Carol Neese College of Nursing is an approved provider of nursing continual professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Center Commission on Accreditation. At this time, presenters, organizers, and content specialists have indicated no conflict of interest. This activity has been submitted for 1 contact hour for participants who hold a valid RN license, attend the entire session, and complete the evaluation. Partial contact hours are not awarded. This program is being provided by the Penn State Neese College of Nursing's Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence, in collaboration with the Center for Nursing Research and Age-Friendly Care, which is funded by HRSA. If you have any questions at all or any comments or feedback you'd like to provide us, in addition to doing the survey tool, you can always reach out to us via email at cgne@psu.edu. And now it's my pleasure to introduce one of our affiliated graduate students who joined our center this year, Nahida Atker, who is going to be introducing our speakers today. Thank you, Nahida.
Thank you, Denise. Denise Getgen, Director, Protective Service Office, Pennsylvania Department of Aging. Denise has worked for over 29 years in various registered nursing roles in cardiac or respiratory intensive care units and corrections. She has worked for the state of Pennsylvania since 2000 for both the Pennsylvania Department of Health and the Pennsylvania Department of Aging. Denise assumed her role as Director of Protective Services Office in 2015. The office is responsible for the administration and implementation of the statewide Older Adults Protective Services Program. And then we have Stephanie Cole, Special Assistant to the Director of Special Projects, Pennsylvania Department of Aging. Stephanie worked in private sector leadership roles for 15 years prior to allowing her passion for the older adult community bring her back to the work she loves. Years after moving away from the field, Stephanie felt herself finding ways to make her work all about the people and in particular older adults. Taking a chance, she opted for a mid-career shift back to the field at the Pennsylvania Department of Aging and has held role in quality assurance and supervised the department's data collection efforts. now working directly for the Secretary of Aging. Some of our major projects have included championing the department's 4-year federally required state plan on aging, leading the department's outreach and inclusion efforts with the LGBTQ older adults community, and developing the partnerships and collaborations that helped respond to social isolation during the COVID-19 pandemic and beyond. Thank you.
Thank you, Nahida. I appreciate that welcome. I just want to take a moment to thank the Denise and Helen Diskovich Center of Geriatric Excellence and really the entire Penn State College of Nursing for having us and for hosting us. So thank you very, very much. So I really am so thrilled to be here really to talk about what nurses and other healthcare professionals should know about the work that we do around protective services. So just want to spend just a few minutes talking about the laws. So we are lucky in Pennsylvania. We have the 3 laws that cover the lifespan. So we have Child Protective Services, we have Adult Protective Services, and then we have what we do, Older Adult Protective Services. The Adult Protective Service Program is housed at the Department of Human Services and serves individuals 18 to 59 years of age living with disabilities. The Older Adult Protective Service Program is housed at the Department of Aging, and that serves individuals, older adults, age 60 and over. These laws focused around adults are very similar, so sort of everything I'm about to tell you about the Older Adult Protective Service Act is very, very similar to what you would expect to find in the Adult Protective Service realm as well. So really just talking about all adults, specifically want to talk a little bit about OPSA, the Older Adults Protective Service Act. Was written in the late 80s, has 3 parts: voluntary reporting. So you're just a person in this world, you suspect abuse, you can report that to your local area agency on aging, and there's a system of protective services that can look into those concerns and to act to investigate those, and then to put in services to decrease or eliminate risk. The second part of the law centers around mandatory background checks. So individuals who want to work in long-term care settings get criminal history background checked. Everyone gets the state police check. And then if you've been outside the state of Pennsylvania 2 years preceding your application, then you also need the FBI check. So that's that portion of the law. And then there's mandatory abuse reporting. And again, this centers around individuals working in long-term care settings. So employees or administrators of facilities who suspect abuse are required by law to report that to their local area agency on aging. The older or the Adult Protective Service law that came into play most recently has 2 parts. There's voluntary reporting and of course the system of protective services, and then mandated reporting as well. So generally speaking, just these laws really speak to and serve adults and older adults who lack capacity to protect themselves and are at imminent risk of abuse, neglect, exploitation, or abandonment. Of course, there should be access to and provided with services necessary to protect them. I wanted to spend a minute just talking about capacity under this law. So when we say capacity in protective service, we're talking about either a physical incapacity or a cognitive incapacity or both. And then a minute on imminent risk, although this is not defined in our law, we look to just a very common definition. I want to give you an example so you sort of understand how imminent risk really varies from county to county. So there was a protective service case not too long ago where older adult is reported living in a very, very dangerous environment. There was a hole in the individual's roof. They were sleeping wrapped in newspaper. It was extremely cold out. We went to court hoping that the person refused services. We went to court hoping that we could help this person. We could get a court order. That court order was denied because the judge felt that we did not have imminent risk. So protective service just doesn't walk away. We had to wait and work with that person and gain, sort of work on gaining rapport with that individual. And we ended up going back to court a few days to a week later Same sort of situation. There's a hole in the roof. They're sleeping literally wrapped in newspaper. At that time, it had been snowing. There was snow on the ground, snow, of course, coming in the home, and the individual was demonstrating signs and symptoms of frostbite. At that point, we went back to court, and the court order was granted for an involuntary intervention because they felt that the judge felt that at that point we did have imminent risk. So all that to say that in your county, there may be very, very specific requirements in terms of what they'll consider imminent risk. So I wanted to talk a little bit more about this law, safeguarding the rights of older adults with disabilities and incapacitated older adults, while still protecting them from abuse, neglect, exploitation, or abandonment. So a couple things come to mind when I was preparing for this, just thinking about an individual's right to consent to services or to refuse. And really, for us, it depends on the level of risk, and it really hinges on capacity to make decisions and understand the consequences of those decisions. So those are the kinds of things, I mean, our protective service law has some really good pieces where it talks about older adults having the right to refuse some or all of protective services. So the way that we train our protective service staff is to then look towards capacity. Are they able to understand the decision before them? This law also provides for the detection, reduction, correction, or elimination of abuse, neglect, exploitation, or abandonment. I want to just talk about that for a minute. So this word detection for me is very important. It implies that we do have the authority to investigate. Reduction, it's all about for us mitigating or alleviating some of the identified risks. Sometimes we can't mitigate or eliminate everything, but we certainly can work on those kinds of things. Correction, it implies elder justice. So it's not enough for us to quote unquote stop the bleed. Rather, we should work towards elder justice, whatever that is. Self-determination certainly comes into play there as to what an older adult wants us to do after the investigation is completed. And then elimination is, can we, I mean, our hope is to eliminate all identified risks. But going back to that reduction, I mean, I think there's times where all of us could see that we can't always either identify all risks, nor can we reduce or eliminate them totally, but we certainly can work towards those two things. Elder abuse, just talking about the World Health Organization, their definition varies a little bit from the Older Adult Protective Service Act. And I wanted to point that out because you too have to look to what is your definition of abuse in the world that you work in. So maybe your facility has their own definition of abuse and they have their policy. So I just want to bring that to your attention so that you're looking at and working within your requirements. So based on what the WHO's definition, a single or repeated act, a lack of appropriate action occurring within any relationship where there's an expectation of trust, which causes harm or distress to an older person. So of course, there's physical abuse that could be willful or non-willful, violence or injury. There's psychological or emotional abuse, verbal abuse, exploitation, sexual abuse, whether it's sexual abuse as defined in the Crimes Code or whether it's a sexual harassment type of situation. There's also, of course, financial exploitation and abuse, and then the neglects, whether it's self-neglect or caregiver neglect, and abandonment, is literally abandoned typically in the community. So in Pennsylvania, again, just showing you a little contrast, according to the Older Adult Protective Service Act, abuse is the occurrence of one or more of the following. So there's the infliction of injury, unreasonable confinement, which I like to call restraint. I mean, I think that's most how we, as people that are clinicians, really think about it. It's unreasonable confinement, sort of a restraint type picture, intimidation or punishment with resulting physical harm, pain, or mental anguish. The second part of this definition is the willful deprivation by a caretaker of goods and services necessary to maintain physical or mental health. And I bring that up because when you look at the definition under this law, under OPSA, when you look at the definition of neglect, that word willful goes away, but that same sort of phrase is used, but the word willful's gone away. So under abuse, it's willful. Under neglect, it doesn't have to be willful. And then in this definition, sexual harassment, rape, or abuse, as defined in the Protection from Abuse Act. So it's the infliction of injury. I mean, I think we're all pretty comfortable with that as people who work in healthcare. Unreasonable confinement, I think we're pretty clear on that. Where it gets a little bit, I think a little kind of sometimes a little difficult to be clear about is this intimidation, this punishment. But I think we can look to the end of this definition where we say with resulting physical harm, pain, or mental anguish, and making sure that we are addressing those in our policy and that we're documenting those when we see these kinds of things. So in Pennsylvania, when we just think of just general abuse, we're thinking physical abuse, emotional abuse, verbal abuse, sexual abuse. And then we have the neglect that sort of is a very different thing than abuse. So, okay, so in Pennsylvania, who are our perpetrators of elder abuse? Again, unfortunately, family members, but who really are they? They're adult children, typically grandchildren, siblings. Of course, there's other family members who may be involved, but generally speaking, I would say the vast majority are adult children, grandchildren. They're caregivers, so who can be a perpetrator? Certainly caregivers. They're direct care workers who are literally providing hands-on care, intimate partners, friends, and persons both known and unknown to the older adult. And that unknown, when we talk about scams, we typically are thinking unknown to the older adult. And when we talk about sort of abuse, we're usually are talking about people who are known to that individual. So why are these people perpetrators? What happens there? I mean, a lot of what we see, we're seeing a lot of financial exploitation. So it centers around greed. There is some level of retaliation. Unfortunately, we've seen plenty of cases where there's physical abuse and an adult child says, well, this is the way they treated me. Now it's my turn kind of thing. We have overburdened, undereducated individuals. There's just general loss, anger, and opportunity. So when you think about, when you're working with individuals and you start to see these kinds of things coming up in conversation, it should be a red flag. Many times they're individuals close to the victim, and so there's a sense of entitlement. And if they're unknown to the victim, there's no attachment. So there's no concern that they're hurting anyone because they don't even know this person. So risk factors, who are our victims in Pennsylvania? Typically, they're females, caretakers, mothers. When you think about the roles that many women take, they are caretakers, they're mothers, very sympathetic. They may have some cognitive impairment, a dementia. They're a very easy target. They are dependent on the abuser. There could be social isolation. There's nobody there that's going to report or to tell. So, and of course, physical disability. So there's that potential dependence upon one another. In terms of perpetrator risk factors, I mean, the kinds of things we've seen in thousands and thousands of cases that we've looked at over years, we see that a lot of perpetrators are experiencing high levels of stress. They are abusing either some substance, whether it's drugs or alcohol. They may have a history of mental illness. They may lack social support, underemployed or unemployed, and very typically dependent upon the victim for finances or housing, transportation, those kinds of things. So again, when you're working with individuals and you start to see these things in the people that are bringing people in to see you, if you're a clinician, keeping our eyes out and looking for these kind of risk factors. Wanted to share with you a little bit about what's happening in Pennsylvania. So I've been doing this for about 15 years. And every single year, we've seen an increase of 11 to 26%. We don't see that kind of increase in other kinds of abuses, not child abuse or domestic violence, not animal abuse, but there's been huge increases. And we sort of attribute that to both more awareness, better training, but I think also people are really starting to understand what elder abuse is. So we have about 39,000 allegations of elder abuse coming in annually. About 85% of them are appropriate for us to investigate. And 35% of those, or around 11,000, are substantiated, meaning the older adult is in need of protective service, either at the time of the incident or at the time we're investigating, or sometimes both. 62% of our alleged victims are female. So again, it starts to give you a picture in your mind of who you're looking for. Over half the victims were either widowed or single. They lived alone. Nearly half of the reports of need, that's our intake form, half of the reports coming in the door were categorized as either emergency or priority. So these are cases that are very, very serious, require immediate attention by protective services, either literally immediately or up to 24 hours. Wanted to share with you a little more of what exactly we're seeing. So as you can see by the numbers there, the neglects by far, and this has been literally every year since I've been doing this work, self-neglect is the #1 reported and substantiated type of abuse being known to protective services, followed quickly by caregiver neglect, and now financial exploitation. So you can start to see, what's really coming to the forefront and where we really need to put efforts in. Now, I do have to say, I do worry about the numbers of things like physical abuse and sexual abuse, because we all know that elder abuse is underreported. And so I do worry about those numbers a little bit, but in terms of the data that we have, this is what it looks like in Pennsylvania. Family members are the highest category of reporters, followed by hospitals. Okay, we can go to the next slide. Thank you. In terms of in the clinical setting, what might you see? Bruising, we look for patterns, we look for repeat injuries, and we look for widespread, where we see a lot of injuries over a large part of the body. We also are seeing burns, scalding, and other skin conditions repeated. Typically, we see a pattern where these things are repeated. Pressure sores, malnutrition. Often there's victim blaming with not only just malnutrition, but many of these where they say, oh, this individual, oh, she won't eat anymore. But really underlying that can be abuse and neglect. We often see depression or other mental health conditions. I wanted to just speak to the bruising being hidden. So many times you're going to be the only one who really has an opportunity to even see bruises that you wouldn't see if the individual was dressed. So I can't tell you the number of cases that we see where it's reported by a caregiver or a family member after the person's been undressed or they've been showered or those kinds of things, where just to maybe someone on the outside, you wouldn't see those things. And then of course, missing early identification of the injury. So what we're seeing is someone goes into an ER with a stage 3 or stage 4 pressure sore, but it's never been reported earlier. So no one reports that there's redness or the start of skin breakdown. It's really, they don't report until it's so far gone that the person is either maybe, could be by that point septic. So just worry about when they're missing early identification or early reporting of injuries. In terms of victims showing subtle signs, we see a lot where we see repeat visits for the same issue or missed appointments. So we get very concerned in protective service when we see repeat reports coming in, especially if they're from different reporting sources. So just keeping an eye out, red flag for repeat visits for the same issue or very vague complaints. Withdrawal or depressed mood, we see that a lot. A lot of these individuals will present with minimal or low social support. So sometimes they're just dropped off, but there's no one there to call. Whoever you can call, they don't answer. They disappear for hours at a time. Just very little support to the older adult. Many times they deny knowledge of abuse or abusive behavior, especially, of course, in the presence of the abuser. So many people will deny that any kind of abuse is going on. But we do try, at least in protective service, to have a means to interview these individuals alone and discreetly. We often see non-compliance with treatment. And so when you start to see non-compliance, you have to at least, I hope that all of you will consider Is there abuse going on? Is there neglect going on? Could that be a possibility as to why ordered treatments are not effective? And then, of course, I would just say that, the easiest sort of thing that sort of gets reported is poor personal hygiene and weight loss. I think that's just a very outward sign that something's happening. So a lot of times our reports start with those kinds of things. So there is reluctance of our victims to report. So I would not at all be surprised about individuals being reluctant or out and out deny abuse, because of course, these people, these older adults are reliant upon these perpetrators, maybe for care and services, maybe to see grandchildren, maybe financially, maybe for housing, that kind of thing. So there's an absolute reliance upon them and a concern about, if this gets reported, what will happen? There's, of course, fear, just out and out fear of the perpetrator. So when protective service goes home, what's going to happen if I admit that something's happening and then I have to live here with the perpetrator? What's going to happen to me? We often see a sense of hopelessness. Many times older adults are dealing with children who they've dealt with for a long time, which may again have drug and alcohol abuse issues. They may have mental health, undertreated or untreated. And so there is a sense of hopelessness that anything's really going to change, even with our intervention. Of course, they worry about institutionalization. I think we all know people want to live in their home. They want to remain at home. So they're very, very concerned about being placed into a facility setting. There's often shame and embarrassment because they raise these individuals. Oftentimes we say that these are family members. And of course, an older adult would not want to admit that their child or someone in their family would do this to them, or that this would even happen to them. And then of course, the negative outcome for loved ones. There's always a concern, what's going to happen to my son? What's going to happen to my nephew if I say anything? I don't want police involved. I don't want someone to get arrested. I don't want them to have to go back to jail, those kinds of things. So again, reliance on the perpetrator for assistance, transportation, family ties. I mean, often it's that when we go and we try to have a conversation, they don't want to do anything because they don't want the family ties broken. So in protective service, we're very, very careful about our reputation. We don't want a reputation. We don't want anyone to think we come, knock on the door, knock down the door and put people in facilities, because that is not what we do. Many, many cases, we're trying to maintain family relationships, even caregiving relationships. So we just want to be very careful about that as we approach things. The fear of the perpetrator, we talked about that. Loss, I wanted to just spend a second on this. There's a concern about just general loss. I mean, just there's loss in aging, but there's also things that they're concerned about: losing their home and their assets, losing their independence, losing relationships, losing access, losing any kind of social interaction. So there is this sense of, if I report, what's going to happen? If I go forward with any kind of intervention or trying to get someone help, what's going to happen in terms of loss? Okay, I think we can go to the next one. Perpetrators, what do they look? What really you might see: controlling behaviors, anger and frustration with the older adult, demeaning talk or talking over the older adult, repeat requests for medications. I mean, I'm sure some of you have seen this, where everything happens to the older adult's medicines. They're lost, they're spilled, they can't find them, all these kinds of things. And again, just a red flag. Many times when protective service attempts to address some of these cases, there's a refusal to leave the older adult alone so that they can be interviewed. And so that really should raise a red flag for all of us. And then this disparaging remarks about the older adults: she's crazy, she doesn't know, she doesn't remember, those kinds of things. Just want to talk a few minutes about reporting. Again, voluntary reporting. Any person having reasonable cause to believe that an older adult or an adult with disabilities may be in need of protective service may report that to the local area agency on aging. So under voluntary reporting, you don't have to prove a thing. You just have to have reasonable cause to believe that an older adult or adult living with disabilities needs protective services. And you would have immunity for any individual reporting in good faith. Under mandatory reporting, this is really based around employees or administrators of facilities. So by facility in this law, nursing home, personal care home, daycare, dom care, home health, and many of our other facilities by policy at the Department of either State Department of Health or Department of Human Services also fall into who's a facility. So employees or administrators are required by law to report any suspected elder abuse. So I want to talk about this. As you know, I am a registered nurse. I mean, I did not know this until I started inspecting nursing homes. But when everyone asks me, am I a mandated reporter? I want to make sure that nurses understand that in our Nurse Practice Act, it already talks about what we should do if we come across abuse. So it talks about the registered nurse shall respect and consider, while providing nursing care, the individual's right to freedom from psychological and physical abuse, and act to safeguard the patient from any incompetent, abusive, or illegal practice of any individual. So for me, we already are mandated reporters because our Nurse Practice Act says we will act to protect these people, and reporting certainly would go along with that. And then there's another piece that talks about the registered nurse may not knowingly aid, abet, assist another person to violate or circumvent a law or a board regulation. So of course we have laws that talk about, things like assault and abuse, those kinds of things. So I just wanted to make sure that all of you who are nurses, have an opportunity to take a look at this part of our Practice Act for yourselves. So what happens when and if you experience protective services? There's going to be two ways that you come in contact with protective service. Either protective service is going to be calling you because they got a case and you may be the provider or working with that individual in some way. Or you may want to report. You may suspect abuse and either be a mandated reporter, or even in your personal life, you may suspect abuse and want to be a voluntary reporter. So I wanted to give you a sense of what happens when you report. So first of all, I told you our report of need document. So the report of need, the allegation is received. We categorize it or prioritize it. That just tells us how quickly do we need to get out there? What kind of risks are involved? Then we conduct our investigation. We do a face-to-face visit with the older adult. We may do some observations, some interviews, identify collateral contacts such as doctor's office, advanced practice, individuals who we need to interview because they're working with this individual. It could be banks, it could be neighbors, it could be roommates, it could be nursing staff in a facility. So we identify collateral contact and interview those individuals. We also do record reviews, whether it's financial records, whether it's medical records, legal records, power of attorney documents, that kind of thing. So we'll do this full and comprehensive investigation. And out of that comes a determination whether this case is substantiated or unsubstantiated. Substantiated meaning the older adult's in need of protective service either now or at the time of the incident. If a case is substantiated, then we do a service plan or a care plan. We sit down with the older adult if they're capable and develop how do you want us to address this issue? How would you like to see this resolved? What kinds of things would you like done to resolve this issue? And of course, once we get that sort of ironed out, if you will, then we ask for written consent. Now, as I said earlier, an older adult has the right to consent to all of what's being offered or part of what's being offered, or they can refuse it all if they have the ability to do that. Once we get a service plan that we all have consented to and feel comfortable with, that service plan is implemented. And then we assess that plan for effectiveness over a short period of time. And once the risk has been reduced or eliminated, we can close that case. So that's just in a nutshell, sort of what you can expect from protective service. But just a couple things. One is I want you to know that you should never, ever, ever have a time where you report to the Area Agency on Aging and they don't take a report, because this is all based on if you suspect elder abuse, you are required to report. So we should always take the report. Your report will be investigated. And then this idea about putting in services, Our services really can be anything. Our law is very open there. It really gives us wide discretion as to what we need to do. So it could be as easy as interviewing and then educating family about injury prevention, about restraint use, about those kinds of things, all the way up to and including something as restrictive as guardianship. And really, we've done all kinds of things in between, as I'm sure many of you have. Things like we've boarded dogs so that people, hey, I'm not going to go to the ER, I'm not going to get this wound looked out because I'll get admitted. And I'm not going to do that because I have 3 dogs. Nobody's going to take care of them. So we've boarded dogs. We've even got them vaccinated, boarded them, had the person go get treatment, and then come back out and reunited them. So, I mean, and anything in between, really, working with collaborative partners such as mental health, drug and alcohol, just all kinds of sort of collaborations, domestic violence, sexual assault providers, to try to really get a service plan that reduces or eliminates the risk. So what can you do? I never want to miss an opportunity, the kinds of things I think all of you could do as practitioners to talk about this issue, to let people know that there is elder abuse, that there's abuse of individuals, targeted abuses of individuals, both older and those living with disabilities. Talk about that publicly, talk about that with loved ones, talk about that with your own staff at facilities. Have good policy about how do we screen, how do we open the door for an older adult or an adult living with disability to share with us something that's happening in their life in terms of abuse or neglect. How do we write good policy about if staff identifies abuse, what do they do? How does that really work? We need to empower our staff to stop the abuse, of course, if it's a safe situation, and to immediately report. We need to intervene early as practitioners so we can prevent some of these things. I mean, I think that there's a fair amount of things that happen because older adults didn't pre-plan before that opportunity goes by. So we just want to make sure that we're talking about intervention early as people start to get diagnoses or you start to see some cognitive impairment, to start having conversations about who's going to be helping you, who is a person you trust, who is someone I could talk to if I have concerns about you or your health moving forward. I hope that all of you are having those kinds of conversations or would consider doing so. I also hope that you'll consider looking at your area agency on aging, seeing if they have an elder abuse task force and how we can all continue to work together moving forward.
And I'll take it from here, Denise. Thank you.
Thank you.
Hopefully you can all hear me. So I'd like to talk a little bit, and good afternoon, everyone. I'm Stephanie Cole, about how certain risks can be addressed that can help in preventing elder abuse. So certain risks, yes, it can be addressed by responding to factors and risks that make clients and patients more susceptible to abuse, like, for instance, social isolation. I know that we haven't always talked a lot about social isolation, but I imagine that many of you have heard a lot about this as a huge social problem that has only increased exponentially during the pandemic. The United Health Foundation recognizes race and ethnicity, immigration status, sexual orientation and gender identity status, level of English proficiency, as all as contributing factors to socialization. In addition, those at greater risk include individuals living in poverty, those living with a disability, individuals who live alone, individuals with one or more ADL difficulty, and then individuals with a marital status of never having been married, those who are divorced, widowed, or separated. So just pointing out before we change slides, those risk factors, if you think about, I know Denise had gone over some of the statistics of who exactly in the state of Pennsylvania for our last fiscal year, who were victims of elder abuse. Many of the highest numbers came from folks with these risk factors. So over half of the victims lived alone. I think it was greater than 60% had marital statuses in this list, and many had a decent amount of ADL difficulties. So you'll see that this social isolation is in the scholarly research proven to be a risk factor for abuse. Next slide. So interestingly, social isolation is both a risk factor and is a result of elder abuse. And let me explain why. So having limited social supports and networks may make it more difficult to get out of the house. So ultimately, some adults are less able to take advantage of opportunities in the community, and they might be vulnerable to abuse because they're isolated. But also, victims of abuse who are being abused, they may be, because they're being abused, they have feelings of shame. Those feelings can be isolating, and those victims are often prevented from having access to their friends and loved ones. And this contributes to isolation. And also, those experiencing abuse will normally become more isolated as that abuse worsens. So next slide, what does isolation look like in Pennsylvania? I'm going to give you some quick statistics on the clients that we serve at the Pennsylvania Department of Aging, just globally, so that if you're not aware, Pennsylvania has over 3.4 million people over the age of 60 in the state. So we don't serve at our department every single one of them, but in our databases, we have about 550,000 individuals who have in some way touched one of our area agencies on aging and are in our system of data collection. So recently, about in the last couple of years, we decided to run those risk factors just to see, well, where do we stand? Are there people we could outreach to and ensure that they have, the proper outreach and services that they need, so that, although we may not be able to take away the risk factors, we could ensure that they know that there are services and supports out there so that they don't feel so alone in the community. So of those clients, we found that 7,200 people across Pennsylvania have all 5 of those risk factors for social isolation. And then over 41,000 had 4 of the 5, 89,000 had 3 of the 5. And then interestingly, almost 300,000 had the either single, divorced, widowed, or separated marital status. 174,000 lived alone, and 72,000 of the 550 had 6 or more ADL difficulties. So there's a lot going on with people who are over 60 that can, give them not only make it difficult, but give them a lack of motivation to, get out there and leave their home, and can be frustrating at times, and, be very isolating from friends and people they used to, be with and be social with. Next slide. So how can you address this? Well, first of all, knowing those risk factors and recognizing and acting upon them can help. So having that conversation with them, clients and patients can become more compliant when they know someone's concerned. Hey, have you talked to any friends lately? Have you engaged with any of your family lately, or who do you consider your family? Having those conversations so that they know that you're aware that they might be alone. Increasing contact plans with patients that have these risk factors, where risk is higher, can help ensure that outreach is a little bit better so that they're not so isolated. And then offering resources in the community, that can always help too. And starting with your local area agency on aging is a great first referral, because they have all of the tools in their toolkit to get that individual to whatever local resources are there that can help that individual. Next slide. And then, of course, I couldn't pass by the opportunity to talk about age-friendly health systems, the 4 M's, and how they can impact detection, because the Penn State Ross and Carol Neese College of Nursing Age-Friendly Care, and their collaboration with the Primary Health Network, has done a fantastic job of pushing out age-friendly health systems and the 4 M's in Pennsylvania. And there's been some research on how this work can help to in the prevention of elder abuse. So the age-friendly health systems movement is grounded in reliable implementation of evidence-based practice, care that causes no harm, and care consistent with what matters to the individual and their loved ones. The 4 approaches of age-friendly health systems, and I'm sure many of you are aware of this, is so what matters, enabling older adults and their healthcare team to be clear with family members and loved one about what matters to that individual. Medication, using medications that are known not to impede what matters to the individual. Mentation, supporting brain health and emotional well-being. And then mobility, ensuring that every day includes safe physical movement. And of course, as you heard, the emphasis always leading back to what matters. So age-friendly health systems and the 4 M's. So how does this help detect elder abuse? So the 4 M's used across the care continuum for the benefit of the older adult. These multidisciplinary teams, basically speaking the same language, can help detect abuse because first, it creates a broader system of surveillance because all the care continuum is all talking to the older adult based on the 4 M's. It builds on the strengths of the individual care setting. It helps define the risk factors for the older adult. And it keeps an emphasis on what matters, as I mentioned earlier, and it supports the caregiving relationship. So let me give you an example of an older adult. So say the older adult is taking high-risk medications. Those medications impair their mobility, so therefore they can't go out. Not going out is increasing their isolation. The increased isolation is impacting their mentation. Together, these are impacting what matters to the older adult. So in an age-friendly health system, the coordination is to ensure what matters is first, and this promotes better independence of the individual. And when this happens, it becomes more obvious to the provider when what matters is unfulfilled. So I just wanted to throw that out there because this is a way to more clearly have it become obvious when something is out of sync with that older adult. And I think it is a great way to sort of highlight that when things don't seem like they're exactly right in a clinical setting. Next slide. So this is just some references of some materials we use to create our presentation. Next slide. And finally, so this is our statewide reporting hotline. You can always call local AAA to report elder abuse, but this hotline is available 24 hours a day, 7 days a week, 365 days a year. Please write it down. You can find this number also on our website, and share it and call anytime. And then finally, the last slide. Denise and I are always happy to hear from you by phone or email with any questions or needs that you may have, anything questions you have for the entire Department of Aging. We're happy to field those as well. So we thank you very much for your time today.
Well, thank you so much, Stephanie and Denise, for that outstanding presentation. The review of the law, the regulatory standards, and some very key concepts related to abuse, neglect, treatment of older adults, how to report, all very important. And, Stephanie, thank you for making that connection to social isolation as well as age-friendly care and the 4 M's. So thank you for all of that amazing content. People that are participating today, if you have any questions or comments, please feel free to put them into the chat box and I'll read them aloud to our presenters. Donna Fick is saying excellent presentation and wonderful connection to the 4 M's framework. Thank you. And I know that, all of our participants are feeling the same way. So one thing I was curious about, you shared data from the last year, but I was wondering how that might compare to previous years, prior to the COVID pandemic. Because people were socially isolated, did you see a decrease in reporting because there were less interactions? or because there was so much stress and, other discord in our society at times, were you seeing an increase? So could either one of you comment on that, or both?
I can start. So initially, right when the pandemic was at its height, we saw a 41% decrease in our reports. And of course, that was very concerning, because the question, of course, always is it not happening, or is it not being reported? And certainly in facility settings, we are very concerned because there wasn't oversight, typical oversight in these facilities. So there wasn't visitation by family members and loved ones and friends and that kind of thing. There wasn't the licensing entities going in. There wasn't ombudsman going into facilities. There wasn't protective service going in. So, it's always a question. So what happened was we saw this initial decrease, and then it popped back up. Now, one of the concerns is I don't think it popped up completely yet. And so you have to wonder what's happening. Is it because people are even isolated within facility settings, meaning they're being kept in their own rooms, and so there's not opportunity for things like resident-to-resident abuse or that kind of thing, verbal abuse? Or is it occurring but it's not being reported? So just want to put in just a thought is, we want to make sure that everyone working in facility settings is aware of our online free mandatory abuse training. So there is that out there. If anyone feels that would be helpful, that's out on the Department of Aging's website, or certainly Stephanie and I can get you access to that. But that may be helpful as well. But initially it went down, it came back up, but it's not quite what it always was in the past.
Thank you. Stephanie, did you want to comment on that as well?
I think Denise did a good job covering it. Thanks.
Okay. So we have another positive comment from Nahida. Wonderful and very informative presentation. Thank you, speakers. And Sarah is asking, as a hospital, we have verbiage in our policy to make reports of the need for suspected abuse. Just curious, do you consider the hospitals to be mandated reporters or voluntary? So I think, Denise, when you were talking about who is mandated, it was mainly long-term care facilities.
Yes, so it's a great question. Thank you for that question. Right now, and it's almost unbelievable even to me, right now, hospitals under OPSA, under the older adult side, are not mandated reporters. Under APS, under the Adult Protective Service Law, they are mandated reporters. So it gets a little complicated. Wouldn't be government if it wasn't a little complicated. So it gets a little complicated. For older adults, they are not. However, that's why I think it's so important for us to, even whether we're registered nurses, whether we're licensed social workers, to know our own Practice Act, know our own facility policy, Practice Act, and the law. So I would just encourage everyone to take a look at that. And I do just want to sort of give you a little glimpse into what's happening. We are in the middle right now of working with the legislature to open the Older Adults Protective Service Act. And if that occurs, and if our recommendations would go through as written, all medical professionals would be mandated reporters. So it wouldn't be based on that you worked in a hospital, but more the fact that you're a medical professional. So we're looking to add law enforcement, and we're also looking to add all medical professionals. So stay tuned. We think that might happen in the spring. So that's sort of where we are today.
And I'll just add on there, Denise, and you may have covered it, but just pointing out again that for us, hospitals were the second highest number of where reports came from, right? And that's consistent with what you see kind of nationally, where reports come from, what the reports are, and then also where they sort of fall off is from just doctors' offices, right? Is that right, Denise?
Yes.
Lower reporting.
Yes. I do think more and more. So when I first started doing this work, we did not get those reports from hospitals. I really think we're doing much better in that regard of sort of saying, no, wait a minute, we're mandated to report child abuse. Of course, we're going to report any suspected abuse. And I think generally speaking, there's really good policy around abuse and reporting and identification and what to do. It's just that the laws haven't caught up with all of that. And that's why I think we see people reporting that by the letter of the law aren't mandated reporters, but they know it's the right thing to do. And ethically, I think people, especially, you know, people who are in healthcare, ethically feel the need to report.
And that legislation you're describing really makes sense because there's so many settings that older adults are cared for by various health professionals. And so to mandate all health professionals to be mandated reporters, you know, really makes sense. Donna Fick is asking about education and training in relation to older adult abuse, elder abuse. You know, we just renewed our RN licenses, many of us, and we needed to update our child abuse training. That was required, but there's no elder abuse training required for that. And at Penn State, we're also annually required to do child abuse training. So any comments about that and how that would be helpful?
I think it would be incredibly helpful. I think it's something we need to work on legislatively, but certainly, I mean, I think everybody on this call for sure understands why it would be so important for all of us to be required to report and to have training about what this looks like and how to report and what that process might look like. So we don't want it to be a fear, you know, people are fearful in facilities to report. We want it to be, no, we're collaborating to really make sure that this older adult and all older adults are safeguarded. So I think that'd be incredibly helpful to have that kind of training available to all practitioners.
And I'll add on there that both the Pennsylvania House and Senate have committees for older adult services. One's at just older adult services, and one's at aging and youth. And you know, petitioning Harrisburg, the legislators, for these changes and updates is very powerful and does help us, because when they hear from us, they think it's the department just asking for help for the department. But when they hear from the public and from especially academic institutions too, it is very powerful.
Something to consider for all of us, for sure. Marie is commenting that it's surprising the lower number of reports in home care. Many people are commenting, thank you so much for this wonderful presentation. And Kimberly's asking, and I think this unfortunately is going to have to be our last question, and then I have, you know, some closing remarks. Can you talk about what types of formal and informal resources are available to help victims of elder abuse recover from the trauma they're experiencing? Really important question in the last few moments, but if you could share a few thoughts.
Sure, it's a great question, and there are resources. So I said under protective services, we can really, you know, sort of sky's the limit. If we feel for whatever reason, whatever happened in this abuse case, the need that this older, we would certainly offer those kinds of counseling and ongoing, but there is a collaboration too between domestic violence and sexual assault, which a lot of what we see sort of centers around those kinds of things. So we partner with them at the local level to see if we can get them ongoing services or victim services, which would include addressing trauma. So that's typically, I would say, how we get that done at this time.
Thank you, Denise. Well, thank you again, Denise and Stephanie, for an extraordinary seminar, something that's so critically important for all of us to be aware, you know, what to look for, how to respond as healthcare practitioners. So thank you so much for this seminar today. And we look forward to continuing to learn more from you moving forward. As a reminder to all of our participants, Jenny just put the evaluation link, the link to the evaluation tool into the chat box. This is required for all RNs seeking contact hours, but we do ask that all participants complete the evaluation within 1 week of the seminar. We will then send out the certificates to RNs that have completed all the requirements for that contact hour. Thank you again, Denise and Stephanie, for visiting our college, getting to know our team here, and as well as this fabulous seminar. It's been a wonderful, worthwhile experience. Thank you so much.
Thank you.
I'm getting lots of thank yous in the chat too.